Okay, life can be crazy. You're feeling like you're sinking, just trying to find a meaning. It's time for better thinking, yeah, better thinking. Time to tune in. Let's go.
So today I have the pleasure of speaking with Bruce Arroll, who's in New Zealand. Really pleased to have him on board, who's allowed me to have a bit of time with him to talk about FACT, or focused acceptance and commitment therapy, and how he's used this. And I suppose today's conversation will start there and then look at, maybe about his use of it, particularly in his role. But I won't take his thunder away. I might ask Bruce to introduce himself a little bit, and then we'll go from there. So welcome, Bruce.
Thanks, Nesh. So my background is I'm a GP in Auckland, and I work in the also in the general practice department at the University of Auckland, where I'm one of the professors on the academic staff. So I've been in general practice for about 35 years, and I work in a moderately high needs practice in South Auckland. And I've been interested in ACT for about 5 years. I started to hear the word ACT. I've always been interested in psychological therapies, and I started hearing the word ACT. And so I started to find out a little about it. I read Russ Harris's books. I went to one of his courses, and then I fortunately had a sabbatical, and I was able to go to Washington State and to spend a week with Kirk Strossel, who was one of the 3 founders of ACT, and he worked in a primary care clinic there in Yakima, which is an agricultural town of about 250,000 people. It's quite a massive clinic, had 25,000 patients or clients, so Wow. It was pretty big. And I spent a week with him seeing what he did, and he and 3 other psychologists provide what's called a behavioral health consultant model. So essentially they're literally waiting for work in the clinic from the family doctors and the nurses and the nurse practitioners. So they keep their templates clear so they can see people immediately where possible, or as soon as possible, within a few days. And that's called a warm handoff, which is an American football term, meaning there's a warm connection from the medical clinician to the psychological or behavioral clinician. And the advantage with that is you don't have problems with follow-up, because the issue when you make a referral, about half of the people don't turn up while they're waiting for help. They get better or they get worse, but they don't turn up. So from that point of view, it makes psychological therapy available to a wide range of people. So I was pretty intrigued with this model, and I thought, well, I'll start doing that in my clinic. Now, I'm only there 3 half days a week, so I couldn't be there all the time. So I don't get very many warm handoffs, but when I do, they go absolutely brilliantly. That's a really excellent model. And I think I found in my clinic here that the faster we can act and respond to, what's going to feel like a crisis or a moment of, acute requirement for the client. If we can jump on that as soon as possible, the better the outcomes as well. In that, first of all, it helps with developing that trust, that therapeutic alliance that's built, and from there everything's kind of built. So we actually have a 1-week policy here, which for I think Australian standards it's quite short, that we make sure there's available times to get someone in. So it's not quite warm like how you said at the ideal, but I think it's a really clever system to operate on. And the sort of follow-up research in the US shows that it's a predictor of a good outcome, because I think, as you say, there's a number of things happening there. People don't have to wait. They're ready to make a change in their life, or they're in a crisis and they're ready to do something about it. And Kirk Strossel talks about getting people back into the river of life. And if you can get people back into the river of life, they start swimming again and getting back into the current. Alternatively, if they stay on the bank, they usually get a big label, and in general practice, they get a drug, which usually doesn't help, because that's not what the problem is. So,
Getting
so
back in
getting
the
people back
river
into the river
is
of life. Yep.
my apologies. Getting back into the river is kind of like engaging rather than
Yes.
from the withdrawal state. They're back into engaged.
Absolutely.
Okay. Yes.
Yeah, I sometimes describe the withdrawal state as, I say to my patients or clients, you're hiding in the back of the cave. We need to get you to the front, talking to people, into the sunshine and hunting lions. And everyone I say that to agrees, which is about, I haven't had anyone say to me, how dare you say that? Pretty well everyone agrees that's where they are, and they realize they need to expand their world. In fact, I often wave my arms in a big circle and say, your life has shrunk. One of my roles is to help you expand it. One of Kirk's great sayings was that life constriction accompanies mental health problems, and it's absolutely profound. We all sort of know that vaguely, but just to actually have it in those words, I think, is genius on his part.
It's brilliant. I think if I talk about, some of the work that I've seen from Kelly Wilson, talking about restriction, mental health is so strongly related to, I think there's studies where they put mice, in a sock, so to speak, and we fed them with, food, water, and the like. But clearly under restriction, they start to exhibit all the signs that we would expect to in someone who might be depressed or agitated, anxious, and the like. And the same can be said with putting a rat in a box by itself, that severe isolation, and what that brings about, and hence why I think the Geneva Convention and those sorts of things. There's a question around solitary confinement because it's torture. It brings human beings who are incredibly social beings into immense angst and mental health difficulties. So that makes a lot of sense in terms of coming back from the back of the cave. It's a nice metaphor.
Yeah, well, Kirk worked this all out. He started off in group health, which is a big HMO in Seattle. And there the psychologists were in a separate building. They were spending an hour with clients and they weren't communicating back to the primary care team. And so there was no communication, very isolated. A lot of people didn't turn up, and it was pretty unsatisfactory. And so over the years, he's got this thing where the psychologists are right in the heart of the clinic. In North America, they all hang out in a big area and write their notes, and they all hang out together. And so they're literally rubbing shoulders with each other, and the psychologists will be saying, have you got somebody for me? Is there somebody who needs smoking cessation? Is there someone not taking their diabetes pills? Is there someone depressed or anxious? They're literally looking for work, and they don't spend a lot of, they see maximum of 3 or 4 visits, and then they get them back to the primary care team. So he calls it a public health approach to mental health. It means you have access to everybody. The problem with spending an hour with clients is that you can't get access to everybody. So he gets it down to about 25 minutes, and that's what I try and do. I book 30-minute appointments in my clinic, although I can do it in 15. If I've got people in the waiting room, it gets pretty stressful. You've got three people in the waiting room, and you're trying to do something in 15 minutes, and something explodes in front of you. Then you start to feel stress. So I book half an hour, which I find is plenty of time, and we seem to be getting good results because we did a little randomized trial in my clinic. And so the effect size, so 50% of people got better in the intervention group and 21% in the control group. So it's about a 30% effect size, which is very big.
That's very considerable. Yeah. So,
and really the intervention for that part of the trial was just behavioral activation. It was getting people committing to doing something over the next week, and we assess them a week or 2 later. And 30% of people were out of the depressed range. Basically, they were mild to moderately depressed coming into the study, and there was a 30% effect size over a reasonably active control.
That's incredible. So one of the features that focused acceptance and commitment therapy is really about access and being able to connect someone's needs very quickly to to a specialist like psychologist, or in your sense, general practitioner, and to be able to then move on very quickly some focused aspects around activation. So getting people engaged, motivated, doing something to get that feedback loop occurring again, versus being on the shoreline, so to speak. So someone who's, rather than being pre-contemplative, they're actually contemplating and let's jump on it immediately. It's kind of like when a salesman goes out and says, we've just driven the nice car, we've gone and done the loop. You're kind of excited, and it's like, oh, this is quite nice. Let's go inside and have a chat and have a coffee. They're trying to sign you up as quickly as possible. This is kind of like, when's the best time, an opportune time where someone might be available to hear it, if they're already in the back of the cave and they don't, they're not open to that at the time.
Yep.
Excellent.
Well, I picked up one nice little tip from Russ Harris in terms of scoring people on a 1 to 10 scale. And he asked how confident people are about doing something. So, for example, I'll say, who's somebody who would like you to give them a call? Somebody who'd be pleased if you, because people have restricted their social life when I see them.
Yes.
And he uses a confidence thing. I use a likelihood. How likely are you to have a coffee with Susan? And if it isn't more than 7 out of 10, I renegotiate. Okay, say, well, a coffee isn't possible. Would a phone call be possible? And I usually do 2 or 3 things. And I write it on a piece of paper and I give it to them, and I get them to read it to me. So I type it into the computer. So there's an extra step, and nobody ever says, I'm not going to do that. They all sort of agree to do it. And by and large, people do it. And if they don't, they usually do something else equivalent. I'll come back and say, well, look, I didn't get hold of Susan for a coffee, but I did catch up with my grandma, and that was great, So it's getting, as you sort of rightly put, getting people back into life. So essentially the first visit I do is just all about behavioural activation. I tend not to do very much else unless they're super distressed. And for people who are super distressed, Kirk puts it nicely. You've got to find what the pain is, like a dentist finding the sore tooth. Find the pain, and it's usually around a core belief, which I know is a CBT term, unlovable or helpless. Or people can actually say what the pain is. I say, when you feel that uncomfortable thought, what button is being pushed? And people can usually tell me. If they burst into tears, I say, if your tears were words, what would they be saying? Which is a quote from my friend David Cool in Vancouver. It's a great line, because when people are tearful, they're completely in touch with their pain, and it's just there waiting for you as the therapist. So then I do a thing called a mindful anger, which is based...
I'm going to jump in. That's so beautiful. I think that's so elegant. If your tears, had words, what would they be saying? That I think that's such a beautiful way to stop and kind of express that feeling, because that feeling is really deep. That's when we're choking up. We're probably holding our breath. We're trying to hold the damn thing in. And by inviting or offering that opportunity, we often can't even formulate what it is, and it's just kind of says, here it is. That's beautiful. That's beautiful.
I'm glad you like it.
I'm going to steal that, if that's all right.
Please do, and spread the word. But the other side of it is it keeps the consultation moving, because I'm trying to do all this in 15, 30 minutes.
Yes.
And if somebody sits there crying for 5 minutes and I'm got a box of tissues, really our wheels are spinning. We're not making progress. Whereas if your tears were words, it gets the feeling labeled, and then I can do something with it. And what I do with it, I didn't realize I was doing this. It's actually exposure therapy. It comes from Kirk and Patty's book, Inside This Moment, which I think is a brilliant book. Actually hasn't sold very well, according to Kirk, but it's got this wonderful 5-step thing. You notice it, you notice the pain, name the pain, apply some self-kindness around the pain. I do a little Kelly Wilson routine around self-compassion. and then just let it go. And what can you do now? So it's what's called the expand moment. So in the old-fashioned terms, you're in the here and now. So what can you do now that you're not thinking about the past and you're not worrying about the future? What may be possible now? And 9 out of 10 people can come up with something that they probably couldn't have at the beginning of the consultation. This can be like 5 minutes into it. It's amazing how quickly you can move when you're working against the clock, which I am all the time. And I've realized this is exposure therapy. So I say to people, I now have a little narrative and say, this thought of being not good enough, your brain won't like. And that's making you anxious. Your brain's essentially seeing a tiger and you can't get away from it, so you're getting anxious. So here's something you can do. And I put their hand over their heart and their feet on the ground. So that's the anchoring. And then I go through this 5-step. It's a mindfulness exercise, but it's not to relax them.
Sure. It's a functionality. So to help me try and, because there was a lot in that for me to try and digest that.
Yep.
Obviously, a client comes to your room, so to speak, when they're ready. There's something that's bothering them. If you notice that there's pain, there's specific pain, you'll invite them to go into that space.
Yep.
And at that point, to be able to notice it is kind of like a bit of a grounding type of experience. Yep. Maybe some diffusion in that, if you can see it.
Yes.
It helps put a bit of distance. Then you label it. Once again, gives further distance again.
Yes. Nice.
And then at that point, you
the self-compassion.
Allow it to be there, or you're kind, compassionate, rather than judgmental of why is it there or there's something wrong with me. You kind of start to have a bit of self-compassion, make room for it, because we can have that internal critic being quite loud.
Absolutely.
And then in some sense of having an open hand to hold that, to make room for that. I think you called it expansion, to sit with that. And I think that what you beautifully summed up is then, how do we then act from there? Going back to that behavioural activation is still so important. But it's not saying we have to stop this feeling in order to act. It's saying I can kind of sit in this position, have this grief, this pain, this hurt, this angst inside, and rather than having to spend all of my time and energy to push it away, remove it, try and drown it, so to speak, I can still act with it.
Yes. Well, there's a great line from Steve Hayes, and I think it's, again, probably one of the greatest lines in psychotherapy. There's no delete button in the human brain. So what do we do with our negative cognitions? He was in Wellington in 2015, and he stood up in front of the audience and said in his sort of slow Nevadan drawl, there's no delete button in the human brain. So what do we do with our negative cognitions? We hold them lightly. And he just cupped his hands and held them down by his waist. And that's the other thing I do if people don't do the mindful anchor. Sometimes people find that a little bit more, a little else. If they're a little self-conscious about putting their hand on their heart, they're not bothered by that. So, and Kirk has a lovely line. He says, the solution becomes the problem. When we try and problem solve personal things, the solution becomes the problem. We get insomnia, for example, is the classic one. We wake up in the middle of the night. If you're your brain is good for fixing your car, paying your taxes, paying your bills, and buying groceries. It actually is pretty terrible at personal things. If somebody insults you, there's no solution to that. But human brain, we go back into problem-solving mode, and that just winds us up. And I see myself doing it a lot. Somebody insults me.
When you say the solution becomes a problem, in terms of, if I'm understanding, is it trying to find the solution or solution? The solution focus system is so helpful if I'm trying to organise, as you say, taxes or how to get my car to the mechanic. But in terms of how do I then try and preempt what's wrong with the car? And how am I going to fix all those things that I don't actually know? And I'm just going, oh my goodness, maybe it's the gearbox, and that's going to cost me $3,000, or it could be that the computer in the engine management system is playing up, and that's going to be an awful lot.
Yeah, okay. No, I like that. That really is that's extending the analogy beautifully. Can I take that one?
1-1.
Yep, one each. Okay. 15 each, 15 love, 15 all. Yep, good. Yeah, so that's what I can. And it's interesting. I just read a paper on ACT about ACT as exposure therapy. This was in terms of PTSD. It's a Jason Luoma paper from 2013. You may be aware of it. And it just goes through the hexaflex, pointing out for PTSD, you're actually doing exposure at every point on the hexaflex.
Sure. Maybe help with our audience in terms of explaining what psychology would traditionally understand as being exposure therapy, and maybe the difference between ACT, how it looks at exposure, whether it be symptom reduction or in actual fact, making room for that space. Maybe you can help us a little bit there, and I'll jump in however I see it, because it's always interesting sort of space to look at.
Yeah. I may not be the best person for this because I lack the basic psychology training, but I guess my understanding is when we're frightened of something, we tend to avoid it.
Absolutely.
For example, if we're frightened of heights, we avoid being in situations where we might be exposed to a height. And one of the ways that humans can heal themselves, and this comes out of research rather than theory, I guess, is by being exposed to it, we become less bothered by it. I think it's called relearning in ACT. I think we narrow our repertoire when we get frightened of things. And what exposure therapy does is allow us to broaden, learn a new way of dealing with a situation. I think they've gone away from the old measuring SUDS, which was before my time, really.
Yeah.
I'm a latter-day psychologist, not a. I won't have had the training you've had.
And SUDS is the subjective units of distress. It's the.
Yeah.
I think I've spent so much time sort of discussing this in supervision with other psychologists, because it's a fascinating thing that I think makes so much sense in everyday world as well, in terms of predominantly exposure to something will reduce its effect on you. So as you say, if someone's fearful of heights, getting them, 10 meters from the cliff allows them to have, subjective units of stress of, let's say 5. And then, we bring them a meter closer and they might be 6. We bring them a meter closer again, they might be 7. But when they step backwards a couple, they feel safer. And so they're no longer as high as they once were. And so if we can kind of do that gradual graded exposure, the idea is that the distress units go down, and that's how we learn to drive a car. The interesting thing that I think the ACT model looks at is that what do you do when the subjective units of distress don't go down? Functionally, we still need to be able to drive, for example.
Yep.
And so maybe I just drive in, for me, when I drive up to Sydney, I don't enjoy Sydney because it's got so much traffic, but I can still go out and drive under that stress that it brings rather than having to avoid it. So, what you're doing is in some sense exposure to the pain, that thing that hurts, and asking them to act anyway, feel the fear and do it anyway. I think there's a title of a book.
There's a book and a song, I think. I think, avoidance seems to be one of the basic tenets of ACT, is that basically psychological distress comes from, we become avoidant when we get psychologically distressed. And I guess we all know that, you leave your tax bill and you leave your tax bill and you leave your tax bill and you finally sit down and do it. And it's never that bad when you finally get it together. And that's just human experience, I think, has just that when we avoid things, it just doesn't make things better, basically. And I often used to say to patients, you need to approach the pain, not avoid the pain, that the personal growth comes out of approaching pain rather than avoiding pain. I think Steve Hayes now coins it in terms of new learning. Rather than extinction of, there's been a bit of a switch. I have to say I'm not fully au fait with that, but I'm quite enjoying learning all these basic psychological terms. The other thing that's quite interesting is that if you're a doctor or nurse, you're not trained in basic behavioral analysis, the antecedent behavior consequence, which is the way we learn most things. I mean, I was taught operant conditioning, but it was about rats and pigeons pushing bars. Nobody ever related it to humans. And Russ Harris has this brilliant thing called a choice point. You can get it on the web if you just put Russ Harris choice point. And it's got a little circle at the bottom which says choice, and then an arrow going to the left saying hooked away, and then an arrow going to the right saying hooked towards your values, like what's important to you. And I found this absolutely brilliant in primary care, because in fact, if you're a GP or primary care nurse, your core business is behavior change. I mean, that's actually what we're doing most of the time. I used to think I was doing medicine, but actually I'm doing behavior change, trying to get people to take medication or not take medication, to exercise, to relax, all that sort of stuff. And I found it absolutely brilliant with anger. And I think it's because people then realize they're just seeing the word choice there in relation to their anger, particularly for men. I think they realize that their anger is a choice rather than something that's part of them. I think a lot of people think, well, I'm just an angry person. But actually, you can turn it on in some situations and turn it on and off in others. That means it's a learned behavior.
I think the nice thing about that, the choice point position is that, there's values I want to go out and move towards. I want to live by things that are important to me. There's values I don't want to move towards. But often we find that it's more attractive to go towards the thing that I don't want to move towards.
Yep.
For example, it might be it's much easier if I'm feeling angry to be snappy at my wife. And it's not necessarily something that I'm really choosing in that moment. I'm just not being mindful, and I'm making a decision based on my emotion, versus the choice point of saying, how do I want to be as a husband? What are the qualities, the traits, the behaviours that I want to go out and exhibit? And so if that's to be patient or thoughtful or considerate, kind, I can behave in that way. So I can actually be angry and behave respectfully, kindly, compassionately, patiently. It's not an easy position to hold, but the avoidance would be that I feel angry, and so I'll just try and quickly get control or avoid these feelings. And so what I might do is I might have some harsh words with a loved one or whoever it might be, without even thinking. It kind of happens, we would almost say automatically.
And we usually regret it when those situations, I think, too. You sort of wish you hadn't done it, but then it's all a bit late. So I guess one of the other things I'd be interested in talking about is the issue of what label do we give people and where does medication fit? Because I give very few people medication. Most people get better by the next visit. After a few visits, majority of people are better. And there's a lovely quote from Alan Francis, who's a psychiatrist in America. He was on the DSM-3, the Diagnostic and Statistical Manual of the American Psychiatric Association, their diagnostic manual. He ran the DSM-4 and has been highly critical of the DSM-5 for overdiagnosing things. And he has this lovely line where he says, the problem with GPs and making mental health diagnoses is that you're seeing people on the worst day of their lives, and you've only got a few minutes. And in America, you have to make a diagnosis to get paid. So they get a label like depression. And then, of course, the medical reflex is if you've got depression, you need an antidepressant, a bit like if you've got an infection, you need an antibiotic. Well, that's often true, but it's for infection, but it's not true for depression, because most of the effect of antidepressants is placebo, not active. The effect size is about 10 to 15%, as it actually is for psychotherapies. We've just had Pim Cowpers here from Amsterdam, who knows all the literature on psychotherapy. And drugs and psychotherapy are about the same. Psychotherapy lasts longer if you, without having to keep doing it, it lasts longer. Drugs only keep an effect if you keep taking them, if they have a benefit. And of course, you never know if the drugs worked or you've had a placebo reaction. That's always the problem. So I think this thing of seeing people on the worst day of their life, don't give them a big label. I think GPs should stop making mental health diagnoses. I think we should leave that to psychologists and psychiatrists, because by the time someone gets to see you or a psychiatrist, there'll be a period of time, and if they're still distressed, they probably are depressed or anxious, and you can make that diagnosis because you have the time. And I just think GPs just need to get on with the problems. So I do a functional assessment. It's called Work, Love, Play. And on my website, there's a copy of the form. It's work is and how things are going with your everyday life, how things 1 to 10, how things are going with your lovers and friends, lovers and intimates, lovers and family. Sometimes that's split up. And then recreation. And then I ask about drugs, alcohol, violence, gambling, religion, social connections, smoking, alcohol, sleep, exercise. And that takes less than 5 minutes, and I scan that into the notes. So it's there. So it sort of industrializes the contextual interview. And there's always someone who's distressed is always going to have something in there. You have to be pretty high functioning to come out of that clean. If you're distressed, you're going to have some deficit there. And sometimes people straight line down at 1 or 2, which is very, they're really flat. I very occasionally, if I see people by mistake and they straight line out at 8, I often say to people, I think you're in the wrong consultation. They've come to me for the wrong reason, or they don't need any more help. And so it's actually pretty easy. There's always something that you can get people doing. There'll be some deficit there, either in the 1 to 10 scales, and that's on my website, and it's all free if people want to use it. We have it embedded into our computer system in the clinic, and my colleagues are starting to use it, and there's always an answer there. Basically, there's always something in work, love, play.
Bruce, it's I tell you what, it's music to my ears, and not because I don't think that GPs can't go out and diagnose by any means, but it really goes out, and I think functionally makes a lot of sense, because we're coming from a functional analysis rather than a diagnostic or category analysis. And I think once we go out and recognise what's the context, the functional analysis in terms of why is someone going out and feeling, for example, low, flat, unmotivated, sad, crying, 3 times a week, feeling helpless, hopeless, etc. We might find that, the context is their workplace is awful, and, they're not quite sure whether they're going to have, a job in 6 months, or they're being harassed by someone that they don't feel they have a voice, or their temperament. Maybe their temperament is one that's avoidant of confrontation. And so they've been sitting in that context for, 12 months. Rather than going out and saying, oh, this person has depression, contextually going out and saying this person's in a workplace where 8 hours a day, they're feeling undermined, they're feeling undervalued, they're unable to speak for themselves or assert themselves or to raise this with anyone, etc. Then we go, well, how else would you feel?
Yep.
Rather than
Absolutely.
going out and saying, oh, guess what, you've got depression and we're going to give you medication, and run that. And that might be, warranted, but sometimes it's not, because it's a contextual thing that the medication isn't going to change the workplace.
Absolutely.
So it's fascinating. That's why I say
Yep.
it's just music to my ears. I'll tell you what, we definitely need GPs like yourself looking at it in that way. I mean, I think Canberra here where I am, we've got fantastic GPs and they do an exceptional job. And, as you say, in that very limited time, but I think describing to one another someone's context has awful lot of value versus diagnostic sort of, exchange of notes.
And unfortunately, GPs are often taught their mental health from psychiatrists. And the problem with psychiatrists is that they see people who are very distressed and have been distressed for a long time. So the context of their life is that medication is probably appropriate and a label may be helpful, but not in primary care. You're seeing people on the worst day of their lives. We keep remembering that. And as you say, we do a functional analysis of their context. I'll tell you a funny story. When I started going to ACT conferences, I'd be telling my GP friends that I'm going to the Association of Contextual Behavioural Science. And I said to them, I don't even know what a contextual behavioural science is. I'd gone to some world congresses before I even quite figured it out. People would explain it to me, and I sort of think, why is that important? But of course, it's absolutely crucial. If somebody's depressed, you got to know the context. It's going to be there's something wrong in their lives. People generally just don't get depressed out of the blue. I mean, there are some people, but by and large, there's something in their environment that's not working, and we've got to find that. And I think if we can get that message across to GPs, that would be fabulous.
Yeah. And I think, the idea of, why is that important, meaning why is context important? When we ask it in that layman's way, why would someone's context have any importance? That seems very silly to ask, but when we look at it from, contextual behavioural science, we go, what's that? But when we look at things like postnatal depression, for example, or PTSD or anything like that, the context will be very, very clear. Why would it be unusual that if I had a horrific car accident that I wouldn't feel aroused, anxious, my heart race, when I approach that intersection again? I mean, who in their right mind wouldn't be? It just makes so much sense that you would be a little bit cautious. And I watched my brother when I was a little boy get bitten by a dog. Well, guess what? That context follows me for a lifetime. So now when I see a dog, naturally, I get a little bit cautious and my heart maybe goes out and increases. I might have adrenal glands go out and fire a little bit. And that's been exacerbated, well, not exacerbated, that's a negative term. That's been increased since I've had children. So now, I'm on the lookout. There's a dog. I'll say to my daughter, "Come here." I'll pick her up. Unfortunately, that's probably how I pass on the fear. In avoidance of my angst, I pick her up, and she goes, "Oh, Daddy's scared of a dog. Therefore, I should be." And that's that behavioural understanding that I think we could do a much better job in learning and applying to ourselves.
Yeah. No, I think GPs and nurses could really benefit from some talks on applied behavioural analysis, and the choice point, I think. So when I teach FACT, I get people to be able to do a work, love, play interview and then initiate actions. So that's the first role play I do. And the second one I do is get them to do a choice point, just because I think they're the two things that are just enormously useful in general practice. They're very simple to learn. You can learn them. Literally, I train people in a couple of hours. When we did the randomized trial, the interviewer had about 2 hours training. She had sat in with me, seeing me do it, but actually I think the training, it just didn't take a lot of training to get her up to speed to do the behavioral activation. I think we overestimate how much training we need for a lot of this stuff, quite frankly. I think the paper chase has meant we do way too much training to get our tickets, and these things aren't rocket science, and we're denying people very effective treatments by not using them. I also could talk about diagnostic labels. So the diagnostic labels I use, I use the word stuck. In fact, we've now got a computer code where you can put stuck in as a diagnostic term. I haven't been able to do it for welfare benefits. I haven't had the courage to put it in. But I actually prefer the word distress, I think, because that captures it a little bit better. But it's interesting when I say to patients, the label I prefer to use, I don't know if you're depressed or anxious, and I have to say in primary care, I find it very difficult to tell the two apart. People who are depressed have always got some anxiety component. I use a PHQ-9 and a GAD-7, and you never see anybody who's depressed who hasn't got some anxious component in primary care. Maybe in secondary care you see a pure anxiety, but it's pretty rare in primary care. And I say to people, I prefer the term stuck. What do you think of that? And they say, yeah, I'm feeling stuck.
That's really it's really nice because it normalizes what that feeling is rather than, makes it a clinical medical term that then means there's something wrong. Because I imagine if I came home from my GP and my wife goes, oh, so what's been going on? What did the GP say? It's very different if I go and say I've got clinical depression versus I'm stuck and I've gone through and I've got some activities to go out and do, which might be I need to catch up with some friends to socialise. I've got to give Frank a call. I'm going to go for a walk around the lake this afternoon, and I'm going to go out and eat a little bit better, and then I'm going to go see my GP again. In 4 days' time. That's a different sort of world versus the I'm clinically depressed and oh gosh, what does that all mean and where's that taken us?
And your wife might say, well, I've been telling you to do that for months and you weren't listening to me. And then you go see your GP and you do what he or she says. So, but yeah, I think partners have a great perspective in these situations, and they're usually quite pleased, I have to say, when I get it. The other concept that's big, in fact, and I guess it's a big thing in ACT, is the workability thing. It's sort of interesting how people do get stuck and start doing unworkable things, like avoiding their friends, avoiding exercise. And one of the things I'm very big on is people not spending extra time in bed when they're not asleep. It's an interesting thing when people get low mood, they start spending more time in bed. And you say, does that help? And people always say no. I drank alcohol all weekend. Did that help? No. Well, you need to probably cut that down because that won't be helping you. So,
and I imagine the behavioural function of both of those, whether it be sleep or drinking, is more than likely going to be avoidance. It's life's feeling terrible, and I can get a little bit of reprieve, a little bit of relief. And so if I'm sleeping, I'm not feeling what I'm feeling. Or if I'm, intoxicated, I'm not feeling what I'm feeling. But, when you wake up the next morning, life is still there, and probably more thoughts and regrets and those things, and maybe even a sore head if there's been some alcohol, which probably, once again reinforces why tonight I should drink again or go to bed because, life's awful.
The other thing I'm very big on is physical activity. It really is the cure for everything. People, I've got an example of a man who was he had chronic back pain and he was on morphine and all the pain-killing drugs. And his wife said, well, now that you're going to the gym, you don't seem to be asking for your medication as much. And I thought, this is crazy. We're giving pain pills to people which sort of don't work. And I think morphine actually makes people, it demotivates people. I mean, you never see anybody on morphine who looks like they're flourishing in life. Literally, I've never seen anybody on morphine. It just really sort of damps down the electricity, as a colleague of mine says. And getting people exercising, if they're not exercising, then it's one of the things I really push. And often say to people, well, if you are a bit flat, you won't feel like exercising, but within a few weeks you will. you need to. So that's where you have to use your clinical sales pitch, I guess.
Can you say a little bit about what you mean by pain medication doesn't work? Because I think functionally there's something in that as to why you mentioned that.
Yeah, well, if you look at the randomized trials of pain medications, like antidepressant, there's about a 40 to 50% placebo response, and there's about a 10 to 15% actual drug response. So most people get no benefit and actually only get harms. And really, there's no magic pill for pain. But in medicine, I often say to the medical students, most drugs don't work for most people. And they laugh at me sometimes, and I say, okay, well, we have a term called numbers needed to treat. How many people do you have to treat to get somebody better? And a numbers needed to treat has to be 1 or 2 to benefit most people. And virtually no drugs have a numbers needed to treat of 1 or 2. Wow. Penicillin for meningococcal disease, isotretinoin for acne. Just about nothing has a numbers needed to treat of 1 or 2, and they're all very quiet when I say that to them. They stop laughing, and I say, "Okay, tell me what has a numbers needed to treat of 1 or 2." And so most drugs don't work for most people. The flip side of that is doctors and medical students are sort of in love with their drugs and devices, and it takes quite a long time to learn not to be in love with drugs and devices, because they don't work for most people. They do work for some, and you never know what's a placebo response and what's a real response. But I'm not anti-medication, and I do give antidepressants to the odd patient, but I have to let time be the diagnostic test. They have to be distressed for 3 or 4 weeks. In fact, Pim Cowpers in his podcast said, just do nothing, because most people get better anyway. Wait and see before you make a referral, give a label, or give a drug. And he also agreed you have to do things like behavioural activation and exercise and those sort of things, and giving people hope. Because on the worst day of your life, the world doesn't seem like a very beautiful place, and that's true for all of us. On the worst day of my life, the world hasn't seemed like a wonderful place, and for someone to give me some hope is very important. And listen to me. As my friend David Cool in Vancouver says, people need to be seen, heard, and understood. He's the tears were words man. Be seen, heard, and understood. Very profound man. Very profound man.
How do you go out? I mean, that's really fascinating to talk about it in that way. It's almost like, a psychologist being vulnerable and saying, there's no doubt that being kind, compassionate, considerate, thoughtful, available for someone has some merit and has some value, and at the same time, that we can also see that you could probably do so with a loved one who's got a particularly, good listening ear. Not suggesting that psychologists don't offer, more than that, and of course they do. But I think the data doesn't always show that there's this exceptional, shift, but rather maybe people just don't have that available for them nearly as much. Is that kind of what you're saying? Like
I think there's a whole informal network of healthcare out there, outside psychology, outside medicine, and people use that and get better and have ups and downs and things. So, but I think it's different when somebody's seeking help, and by the time you get to see a psychologist, things are probably stacking up fairly bad. You've not only had the worst day of your life, you've probably had the worst month of your life. So that's a little bit different, but it's a bit like smoking cessation. Most people quit smoking without any help from anybody. Mm-hmm. A small number do better with drugs and counselling and stuff and nicotine replacement. But, I think we have to remember we're often helping a very narrow sector of society, and with the FACT model, you can widen it out a little bit. You can provide, and that was Kirk Strossel's model of providing a public health model for mental health, that most people in a primary care practice would have access to mental health care quickly if they needed it. I think we just have to keep this in perspective. It's a bit like, I think it's okay if psychologists and psychiatrists do give somebody a label, because by the time they see you, that's probably a reasonable thing. But it doesn't actually help, really, the label. The treatments for depression and anxiety are virtually the same. And I think if you take a problem approach and a function approach and restoring the function, actually, that's a nice word. I'm going to keep that. Restoring the function is what's important.
What's fascinating, I think, is that we often celebrate those people in life that have gone through hardship and maintained or been able to restore their function. So we're not going out and saying the hurt has to go away. We're kind of saying, how do I live with this hurt? And I imagine that, as we mature in life and we walk this earth for a longer period of time, we're just capable of carrying the pain over time, because we've learned to do so, rather than maybe, a younger person who still has some ideals that they're trying to hold on to really, really, really tightly. And, clearly those ideals aren't going to occur. I mean, I love, youth for that reason, because they're the ones that will march out there with, placards and protest and the rest of it. And I think we need them because they're the guys who instigate change. At the same time that those ideals can't be applied across the board willy-nilly, because it'll just create a lot of suffering and the tug of war experience where you're fighting with something you're not going to be able to change.
Yeah, and it's sort of interesting you mentioned that, because there was a study done in primary care in New Zealand back in the early 2000s, and the peak of depression and anxiety was in 20-year-olds. In fact, the 65-year-olds had the lowest level of depression and anxiety. And I think one of the things that happens, one of the nice things about aging, is that you come to terms with your ambition and you realize, well, you're not going to win a Nobel Prize, and you're probably not going to become Prime Minister, and that your contribution to life has probably been okay, and that's good enough. That's about all we can achieve, really. And that actually also plays into, I say to doctors, if you've got a 22-year-old coming in with a headache, really it's not appropriate to look for a brain tumour unless there's something in the history, because my colleagues will rush around looking for the brain tumour. You've got to look at the context. The context of a 22-year-old with a headache is going to be something not working in their life.
I think you beautifully said there as well, what you're doing, is enough. You don't have to be doing more. It's such a beautiful, compassionate space, and something that really attracts me towards the acceptance and commitment therapy model is that it's a very compassionate space that's grounded in behavioural analysis, trying to understand function and form and how helpful that is, rather than the diagnostic sort of sense. So that sounds terrific, the work that you go out and do. How can people find out more about you and your service or training, and the like?
Well, I have a website. It's www.brucearroll.com. Everything's free there. Bruce Arroll is spelled Arroll. And there's a number of videos there. There's the work, love, play sheet. There's also my killer narratives. I have, I think, 42 killer narratives. And the killer narratives are, if your tears were words, what would they be saying? That's one of them. There's a lovely, just talking about compassion, there's a lovely one from Paul Gilbert. I was just in Brisbane last week doing his 3-day self-compassion course. Truly amazing stuff that he does. He says the task of the adult is to cultivate the voice of kindness in their heads. And I try and remember that every day when the world's getting on top of me. And I often say it to my patients or clients, is you have to cultivate the voice of self-kindness. There is nothing else that we can do.
I think it's a beautiful spot to end in terms of cultivating self-kindness. It's really at the heart of so much, and it sounds like that's what you're you're specifically doing with your clients in terms of, what would kindness ask you to do in these 15 minutes, and encouraging
That's
clients
nice.
to do those. So that's beautiful.
I like that. What would kindness ask you to do? Can I have that one?
I'll be downloading your cheat sheet in a minute. So really appreciate your time, Bruce. It's been fantastic and fascinating to hear how ACT can be used or focused ACT can be used in a primary health setting. So thanks, and look forward to talking again.
Okay, thank you.